I will talk today about coronary bifurcations. I will provide a modern stepwise approach based on modern data. And I will provide mainly the details of provisional stenting steps and advanced tips of wiring, ballooning, and stenting in a provisional fashion. In a second part, I will detail the planned, the technical details of a planned two-stent strategy. I will start by laying out the basics by the Medina classification. The Medina classification gives a number of 0 to 1 to the proximal main branch, distal main branch, and side branch. 1 means you have a stenosis over 50%. That's what's used as a cutoff in bifurcation disease. 0 means no disease or less than 50%. So this, for example, here is one example of what we call true bifurcation. You have disease in the main branch and you have more than 50% disease in the side branch. This is another true bifurcation, and this as well. This is what we call 1-1-1. This is what we call 1-1-0 and 1-0-1. So I hope everybody understands that simple classification and what we call true bifurcation. I will elaborate more about the classification in a little bit. This is, for example, an LAD diagonal bifurcation stenosis, and this is what you call 1-1-1 true bifurcation. I will lay again the basics of the idea of stenting. What type of stenting approaches we have in the case of a bifurcation? There are two big approaches that have been studied over the years. One is what we call the provisional strategy, meaning you plan on putting one stent across the main branch and you provisionally, if needed, balloon that side branch, whether before or after stenting. This is what we call provisional predilatation or post-dilatation, meaning dilatation before you put the stent or dilatation after you put the stent. I will use those terms a lot. Predilatation, meaning dilatation of the side branch before main branch stent, and post-dilatation, side branch ballooning after main branch stent. Okay, so we do provisional ballooning of that side branch, and if needed, if provisional ballooning doesn't give you the result you want, you do provisional stenting of that side branch after main branch stenting. So this is what we call the provisional strategy. Planned one stent in the main branch with, if needed, ballooning or stenting of the side branch. Then you have the planned two-stent strategy, where you plan upfront to stent both, often starting with the side branch stenting, then main branch stenting. Importantly, not much talked about, within the first strategy, the provisional strategy, there are two sub-approaches. One is what we call the leave it alone technique, meaning you don't touch it. You can put a wire in it to protect it, but you don't plan on pre-ballooning it nor post-ballooning it unless it occludes. So you really do your best to absolutely not touch it, except wire it and no ballooning. This is what you call the leave it alone technique. The second sub-approach within provisional is where you plan on doing potentially pre-ballooning and mostly post-ballooning and possibly stenting if needed. So within provisional, there is a very conservative approach, and there is one that is a little more aggressive. So we have grossly three approaches to stenting of bifurcation disease. Another thing I want to mention, when we talk about provisional strategy, about 15 to 20%, depending on the subtype of bifurcation, 15 to 20% may eventually require stenting, less so in the more benign subgroup, which I will discuss. So you can stent in the provisional strategy, you just don't plan it ahead up front. So in order to decide which one of those three strategies you will pick, you have to decide what type of bifurcation you have beyond the Medina classification. So throughout this talk, I will be mainly talking about large side branch. And by large, I mean more than 2 to 2.5 millimeter with a large distribution. Most modern or overwhelming amount of modern trials used 2.5 millimeter as a cutoff. And this is what we should probably focus on as far as caliber of the side branch. The first most important distinction in bifurcation disease is true bifurcation versus non-true bifurcation. And that will help you plan what strategy you use. True bifurcation, again, is a bifurcation where the side branch osteum has disease. For example, those three highlighted by the arrows are true bifurcation. This one is not a true bifurcation. You only have main branch disease. You have the side branch arises from the disease, but the osteum has less than 50% stenosis. That's the first subtype. The second most important classification that people don't know well, that is really key in your planning of the procedure, is to understand exactly within the true bifurcation, what is simple true versus complex true. Very, very important classification. This has been derived from the definition prospective study and validated in two Chinese trials, the definition 2 trial and the DK Crush 5 left main trial. So those criteria are the following. What do we call complex true? Complex true means the osteum is not just involved, it's also long disease. A lot, if not most of bifurcation disease, the side branch, when it's involved, it's just the very osteum is involved. When the disease extends beyond the osteum, what we call more than 10 millimeter disease, that's one feature of complex true bifurcation, but that's not enough. You need to have long disease of that side branch, and the disease has to be more than just 50%. It has to be more than 90% in regular vessels and more than 70% in left main. So this is what we call complex true, long and more severe, more than 90% for most of the bifurcations we do, or 70% left main. It has to be also a large vessel, 2.5. Plus, even those are not enough. You need to have a couple of minor features. The bifurcation angle has to be unfavorable, very sharp or very shallow. You need to have some calcification. You need to have maybe multiple bifurcation. The main vessel has to have heavy burden of disease. So you need to have those. If you need to remember those two, and remember there should be some couple of minor ones, such as calcium, angle, heavy main vessel burden. And this slide also summarizes those complex features. This is important because that complex true bifurcation is the only one where there is suggestion of benefit with a planned 2-stent strategy. Everything else is probably best served with a provisional strategy, but only this one is served with a planned 2-stent strategy. So why is this important? Why are those features in the complex true bifurcation important? Here is why. I need you to know those numbers. If you don't have a true bifurcation, if you have a simple bifurcation without severe side branch involvement, the risk of side branch occlusion is very low. I tried to look into many trials and try to find what's the risk of side branch occlusion. And it's usually in the range of less than 2 to 4%, according to some of those studies that I listed here. So it's fairly low. That's why we're not aggressive with those branches. Eventually, that's what you care about. Not just pinching it, will I occlude it? Concerning true bifurcation, the risk of side branch occlusion when you stent across it is high. And how high, it depends whether it's simple true or complex true. Simple true is more than the single digit risk of occlusion. Complex true bifurcation, the risk of side branch occlusion is close to 20% based on the V-score study. And this is why it may be appropriate in those cases to do a planned 2-stent strategy. Okay, so I hope everybody understands this classification. This classification doesn't just explain the risk of acute side branch occlusion, it also explains and correlates with the risk of late target vessel revascularization, late stent thrombosis, and late MACE. Okay. I will just mention a note. I mean, the idea of those complex true bifurcation is that the heavier your burden in the side branch, not just osteal side branch disease, but you have diffuse side branch disease, or even if you have very heavy burden in the main vessel on top of side branch disease, all this correlates with more side branch occlusion, more plaque shift, which causes side branch occlusion. I will comment also briefly on the angulation. You don't want the angle of that bifurcation to be too steep, 90 degree. You don't want it to be too shallow either. You don't want it to be 30 degree in general. And why is that? An angle that is too shallow usually implies that it's easier to access the side branch, but you get more carinal shift and therefore higher risk of side branch pinching after main branch stenting. Conversely, if you have a very steep 90 degree or close to 90 degree angle, you get less carinal shifting, so you're less likely to have a pinching of the side branch, but it's harder to rewire that side branch should it get compromised. So that's why both extreme angles are not favorable. Now I want to talk about the data that studied the two main strategy of provisional versus planned two-step strategy. You need to know the three classic trials that were done in the early to mid 2000s, Nordic 1, Cactus, and BBC 1 trials. Those are very important trials, although they are less relevant today. But all those three trials have shown that provisional strategy is at least as good as planned two-stent strategy, and actually are better. In Nordic and BBC 1, you had less peri-procedural MI with just a provisional strategy. I don't like those three trials too much today, simply because those three trials did not distinguish the three subtypes of bifurcation: simple, true, and complex true. They lumped all together, including a lot of non-true simple bifurcations. Also, they use first generation DES. They are still relevant, but those are the most important trials by today's standard. Those trials are mostly from the last 5 years. Many of them are from the last 2 years. Those are 10 studies. I reviewed every single one in detail, and I reviewed the strategy used in every single one in the provisional arm and in the two-stent strategy. So all those 10, they compared a provisional strategy with a planned two-stent strategy. The important thing of all those trials here is that they did focus on one subgroup of bifurcation. And accordingly, here is the bottom line approach of all those trials. I have slides regarding the details of every single trial, but I will save you that unless you want it, and I'll just give you the bottom line. So one, for non-true simple bifurcation, such as this one, we have two major trials, particularly that one, cross-Korean trial, one of the nicest bifurcation studies I've read. Very straightforward. This study has shown, and Nordic 3, those studies have shown that in simple bifurcation, leave it alone strategy, meaning you just potentially wire the side branch, but then you stent the main branch and try not to touch the side branch at all unless it occludes. This has been the best strategy. This is what we call the leave it alone strategy. It has been shown to be as good as a provisional strategy with touching and post-dilating of the side branch after main branch stenting. So leave it alone is a good strategy for simple bifurcation. For true bifurcation, like this one, those study, including 4 in non-left main and 2 major one in left main and Excel analysis in left main, have shown that provisional strategy, often with ballooning of that side branch, pre or especially post ballooning of that side branch, is equivalent to a planned two-stent strategy. So it's interesting. So even modern trials with modern stents, the overwhelming majorities of those trials still show that provisional is as good as planned two-stent strategy, even for true bifurcation and even for left main for the most part. Here, notice the Excel trial and Noble trial are the two trials that put left main stenting on the map as an alternative to CABG. And both those trials strongly recommended, I don't have it here, but they strongly recommended in their protocol to use a provisional strategy in distal left main. 65% of distal left main in those Excel and Noble trials were treated with a provisional one stent strategy. Even when, in case of true bifurcation, a provisional strategy was favored in those trials. So that tells you that even in left main, provisional strategy is still appropriate most often, okay? Then the third subgroup of trials that applies to the third subgroup of bifurcation, the complex true bifurcation, whether left main or non-left main. Remember, complex true bifurcation, you can have it in left main or non-left main. You just use a higher stenosis cutoff for non-left main, 90% and 70% in left main. So in complex true bifurcation, two trials have shown that two-stent strategy is superior to provisional stenting strategy. And those are the only two trials to ever show really a two-stent strategy to be superior to a one-stent provisional strategy. They had less early peri-procedural MI, which is contrary to those early trials where provisional had less peri-procedural MI. In those, actually, two-stent strategy has less peri-procedural MI, probably because you get less risk of acute side branch occlusion. They also had less long-term MACE, including less stent thrombosis in the DK5 crash complex subgroup, which focused on left main. Okay, so everybody understood those trials, I hope, and how they spread and dictated different treatment for each different bifurcation. Okay. I will now, with those in mind, the different classification, the different types of bifurcation, and the different trials applicable for each bifurcation, I will try to put together, based on that data and on my review of each one of those protocols, I will try to give you an algorithm of how to perform bifurcation stenting, the stepwise approach. Those are the 7 questions you ask yourself each time you face a bifurcation. Should I wire the side branch? Or just wire the main branch and deal with it? Should I use a provisional stenting strategy of that side branch, or should I do upfront a planned two-stent strategy? In provisional, if I chose provisional, should I predilate the side branch before I stent the main branch? In provisional, should I postdilate the side branch after I stent the main branch? In provisional, when to provisionally stent the side branch? In provisional, if a stent is needed, what stent strategy? And if you choose two-stent strategy, which one should you pick? Which technique should you pick? So here is my answer to those. I'll show you my answer. But to the first one, should I wire the side branch? The answer is overwhelmingly most often yes, whether it's true or non-true bifurcation. That's the only strategy that applies to all simple and complex bifurcations. It's been shown that putting a wire and jailing it with a main branch stent, but having the wire in that side branch to protect it, it does indeed protect. It increases your acute success and significantly reduces your acute side branch occlusion. It also, interestingly, improves your long-term MACE, putting that side branch wire by 4.2 times. Okay. Another thing wiring the side branch does is that if the side branch one, it reduces occlusion, but if the side branch occludes, it provides a marker so you can rewire it. Also, it narrows the bifurcation angle. When you put a wire here, it makes that angle narrower so that it's easier to rewire it should you need to rewire it. So wire side branch, yes, for most cases. In non-true bifurcation, wire it if it is large and gives a large territory. So even in non-true, we may wire the side branch. Now, when you decide provisional side branch versus upfront two-stent strategy, most often, based on those trials that I showed here, most often, and even in true bifurcation, you should use a provisional strategy. You use a two-stent strategy for a true bifurcation with a large side branch over 2.5 millimeter with, like I mentioned, extensive, more than 10 millimeter in length, and complex disease beyond the ostium and more severe, over 90% most often. Okay, as in distal left main bifurcation with long and complex left circumflex disease. So that should be a minority. And keep in mind here, even though those trials suggested that provisional, that two-stent is superior to provisional in complex through bifurcation, that still doesn't make two-stent approach mandatory for complex through bifurcation. In fact, one of the most important modern trials, EBC2 trial, European bifurcation group trial, a randomized patient to provisional versus two-stent strategy and including a side branch length, the mean of which was 10 plus or minus 7. So it did include some complex through bifurcation, yet it still did not show a difference with provisional strategy. So provisional strategy is still appropriate. You have to make a judgment. You just tend to favor two-stent in those cases. Okay. So in provisional, once you've decided that you're going to do provisional approach in true bifurcation, for example, should you predilate the side branch? This is a controversial topic. My answer is yes. Most often is yes. In trials, about half of the patients in the provisional approach with true bifurcation received side branch dilatation. This was strongly recommended in the Nordic 4 trial. This one, it was discouraged in the EBC trials, even though if you look here, they discourage it, but about half of the patients still received side branch dilatation. So my approach is to, yes, predilate the side branch often. Now, in provisional, should you postdilate the side branch? And here's the thing. If it is a non-true bifurcation at baseline, a simple bifurcation at baseline, like I said, simple bifurcation, do not touch that side branch unless it occludes. So you only touch it if TME is less than 3. This is based on Cross and Nordic 3 trial. If it is a true bifurcation, then yes, you can potentially touch that side branch if it has over 75 to 90% stenosis after main branch stenting. Some studies, most studies use 75%. It's acceptable to use also a 90% cutoff, and I will explain that later. Now, in provisional, when we decided when to postdilate, well, when do you stent the side branch? You need a higher cutoff to stent than to postdilate. You want to avoid stenting when you're using provisional approach. So you stent if your TME is less than 3 despite postdilatation, which is rare. You know, after you balloon it, you still have TME less than 3, probably from a bad dissection, or you're left with a stenosis over 90% despite dilatation. This is the cutoff used by the EBC group in EBC2 and EBC left main and the old BBC1. Some trials use 75%, but my preference is for 90% in stenting, 75 to 90% to decide about ballooning. Okay. Now, in provisional, if you decide you need a stent, what stent strategy? Overwhelmingly, in modern trials, it is the T-stent and protrusion, TAP, has been used, and I'll explain that in a little bit. You can use also culotte and reverse crush, but overwhelmingly, it should be that based on all those provisional trials. All of them, here the list, all of them used TAP as the approach in provisional stenting. So those who recommend reverse crash, I don't know if their approach is based on evidence, okay? In modern trial of true bifurcation, when you use a provisional arm, about 15 to 20% of patients will require stenting in general, depending on how aggressive of a cutoff you choose to stent. Probably less than 20% if you use a 90% cutoff. All right, so with all those questions answered, I'm going to give you an algorithm and go over the steps. So I have 2 algorithms. So the first algorithm is you have bifurcation, coronary bifurcation with a side branch less than 50% at baseline, simple bifurcation. So you often double wire, but again, do not predilate and do not postdilate the side branch unless TME is less than 3. This is a leave it alone strategy. Even if it develops stenosis, over 75% after main branch balloon or stent. Of course, use your judgment depending how large that side branch is. In left main, if the left circumflex was not involved, it was a simple left main bifurcation, but after stenting, you have over 90% stenosis in a large left circumflex, then yes, you probably should consider touching it. Okay, but in the majority, overwhelming majority of the cases, especially non-left main, you should leave it alone regardless how tight it gets. And if it does tighten, you can really tight, especially in left main, you can consider ballooning, not mandatory, or FFR. And I'll explain FFR in a little bit. And here's the explanation of that approach. Why? I mean, you get over 75%, maybe even over 90%, yet you leave it alone. Why? What happens? And here the explanation entails telling you what happens when you stent the main branch. How does the side branch become pinched? So there are three processes. Everybody thinks that when you stent the main branch, you shift some of that plaque. That plaque that's in the main branch, you push it in the side branch. This is what we call plaque shift or snow plow phenomenon. But actually, there are two other processes that are at least as important. One is geometric distortion. When you put a stent across the side branch, you're changing the geometry. You straighten that segment and subsequently you pinch that ostium. Okay? The carina gets shifted and this may create a pinching. Three, and this is the most important probably mechanism according to a circulation paper published in 2018. When you put a stent, you're pushing, especially when you put a stent that is large, oversized to the distal vessel, you're pushing that lower arm of the main branch forward. And when you're pushing it forward, you're moving the distal vessel forward, you're narrowing the side branch ostium. This is what we call carina shift. You're just pushing the whole lower main branch forward and you're narrowing the ostium even without any plaque shift. That tells you a couple of things. One, frequently the narrowing of the side branch, especially when it's not disease at baseline, frequently is just due to a geometric process. Two, you should not size the stent to the distal, to the proximal vessel. You should size it to the distal vessel so you don't get carinal shift. Okay. The important thing is that the carina shift and the geometric distortion tend to be very focal processes and very elliptical, meaning they will look bad in one view, but they are elliptical. In 3D, the vessel may not be so much compromised. Okay, the vessel area may not be so much compromised, and therefore the stenosis may not be so much functionally significant as it looks. To look bad in one view, but it doesn't look bad in other view, and in three-dimensionally, it's not as bad. And here FFR will help you determine that. Overwhelmingly, they will not be significant despite bad pinching in geographically, especially in one view. So this is an example, and we all learn. So this is a patient who presented with inferolateral STEMI. The left circumflex was fixed. He also had an LAD bifurcation stenosis. It's a 110 stenosis. LAD is involved, but the diagonal is not involved. So here the operator decided to stent across that LAD, and this was the result obtained. There was pinching of that diagonal, maybe in the range of 75%. Based on the algorithm I gave you, this should be left alone because this was a simple bifurcation. You should follow the leave it alone technique. You just wire it, but only do something about it, balloon it if needed, provisionally, only if it is occluded. But the operator here decided to chase it, and this is what happened. As an attempt to rewire that side branch caused the dissection of it. And now the patient is starting to have chest pain. After his STEMI was aborted, he started to have chest pain from that diagonal. Eventually, that side branch reopened just with integralin, more proximal dilatation, and nitroglycerin. But the point I want to make, stick with this algorithm. If you don't stick, bad things can happen, and, it will be hard for you to justify it, okay? So an okay result across the side branch in a simple bifurcation, keep it, leave it alone strategy. Don't try to maneuver and potentially get in trouble with dissection. All right, now I will go to the second big algorithm, the more important one, which is when you have a true bifurcation. So side branch over 50%, and the side branch is large, over 2 to 2.5 millimeter with significant territory. So what is the approach here? Now here we split that into, like I said, simple true and complex true bifurcation. Again, complex true, it has to have many features, long over 10 millimeter, more than 90% in non-left main or 70% in left main, meaning the left circumflex will be 70% in case of left main disease. And you need to have heavy calcium, heavy main branch disease, or unfavorable angle. In those cases, we do complex two-stent strategy. My preferred is the mini or nano crush. You can also do the DK crush and culotte, or tap, a planned T-stenting. The main issue with the planned two-stent strategy is that you have to rewire the stent twice. And rewiring the stent is the single most difficult step in bifurcation stenting. And that's why provisional helps you in that regard. Because in provisional, you maximally have to rewire the stent once. And that's the disadvantage of two-stent strategy. You have to rewire the stent twice. I will explain those techniques in my next talk. I will focus now on the simple true bifurcation. I also want to say that even in complex true bifurcation, I said consider two-stent strategy. It's not mandatory to do two-stent strategy. It's only based on 2 trials. Like I mentioned, EBC2 trial and all those trials of true bifurcation included some complex true bifurcations. And, overall, provisional was still equipoised with a two-stent strategy. So you should consider it, but it's not mandatory. You should individualize based on the case. And one of the big features I use that is not much talked about in meetings and books, one of the big features I use to decide a two-stent strategy in those cases is how easy it is to wire the side branch and how easy will it be for me to rewire it through a stent twice. If I think it will be really hard to rewire it, then I kind of shy away from a two-stent strategy, even in those groups. So that's my approach. I will focus now on the simple true bifurcation. So simple true, like I said, you should definitely proceed with a provisional stenting strategy. And what does provisional entail? And here I'll go through the steps. So 1, you can use 6 French guide, and I'll explain that more. So 6 French guide is perfectly appropriate. 2, you double wire, okay? It's okay to use a polymer wire. You don't wire the main branch and the side branch. It's okay to use a polymer wire like Whisper in the side branch and jail and stent across it. It used to be said not to do so, but it's okay to put a polymer wire, depending on how difficult it is to wire that bifurcation. It's important, if you can, to wire the more difficult lesion first. Like if the side branch is hard to wire, you should wire it first. If you wire the more difficult lesion last, then the complex maneuvering will make those wires, will make that wire twirl and spin, and it can wrap with the first wire. So you do the more difficult one first to avoid potentially wire wrap. When the wires wrap, you'll have a hard time advancing your balloons and stent across the wrapped wires, okay? So you double wire, then you balloon the main branch and you often, like I said, my preferred approach, you often dilate the side branch with a 1-to-1 sized balloon. Then you stent the main branch. The side branch should be dilated just before main branch stenting. So you shouldn't dilate side branch, then dilate main branch, then stent main branch. You should dilate main branch, then dilate side branch, then stent main branch, so that you reduce the amount of plaque shifting, okay? Now, regarding the stenting, the main branch stenting, it's very important, as I alluded to earlier, to stent based on the distal vessel, okay? 1, because as I explained, if you stent based on the proximal vessel, you will push that distal main branch and create carina shift and narrowing of that side branch. That's one. Two, of course, you can create dissection and perforation if you oversize distally. So next step, and so when you stent the main branch, you're jailing that wire, which is okay. You stent across that wire. Next step, and this is one of the most important steps in bifurcation stenting, is to dilate that proximal main branch. This is what we call POT technique, proximal optimization technique. Okay, POT, proximal optimization technique. And the way you do POT, you position a balloon sized to the proximal vessel in front, proximal to the carina. The distal tip, the distal marker of that balloon should be in front of the carina, should definitely not extend to the distal vessel. It should be positioned just in front of the carina. And by the way, your stent should extend in the main branch by the proximal main branch by at least 8 millimeters, simply because you need, the balloons we have available are at least 8 millimeters. So in order for you to do a POT and not extend that balloon into the distal vessel, you need to have at least an 8 millimeter extension of the stent in the proximal main branch. Okay, so you dilate that proximal main branch with a larger balloon. The important thing is that the balloon should be large. It doesn't have to be high pressure, although you can go high pressure. But the most important thing is that it should be large, usually about 0.5 to 1 millimeter large, and I'll explain how to size it. These are more ideas about the POT technique. So when you position the stent, and size it to the distal main branch, you do get some carinal shift. Hopefully, if you don't oversize it to the distal vessel, you're not getting too much plaque shift, but you'll still get some carinal shift. What POT does, it will expand that proximal vessel and it will push the upper portion of the main branch forward, and therefore it will actually open the side branch. It will open the struts in the side branch. It will actually open the whole ostium of the side branch. That's how POT can actually improve a side branch stenosis. If you had side branch stenosis after main branch stenting and you do POT, the side branch stenosis may actually improve. Another thing that POT does, so it improves that side branch stenosis potentially, it opens the stent struts into that side branch stenosis, so it makes it easier to rewire, and it creates good apposition in the proximal portion of the vessel, which allows you to rewire that side branch without going behind the struts. If you rewire here, your wire will have a propensity to go behind the struts. That, after POT, will help you wire properly through the stent struts, not behind them. How do you size the POT? I mentioned it's usually the proximal balloon is 0.5 millimeter to 1 millimeter larger than your stent, and you try to overexpand that stent proximally that much. But you need to know what we call the fractal law. Basically, this is the proximal main branch, distal main branch, and the side branch. The proximal main branch is not equal to the distal main branch and is not equal either to the summation of those. It is equal to 2/3 of the distal summation, 2/3 of the side branch plus distal main branch. And that's how you size your POT. So let's say you estimate that the side branch, or here, let's say we estimate the side branch is 2.5 millimeter, and the main branch where we put our stent is a 3 millimeter. We placed a 3 millimeter stent here, and we're deciding how much we need to POT this. What balloon should we use? Well, it's a 3 plus 2.5, which is 5.5, 2/3 of that, which is approximately 3.75 millimeters. Okay, the same rule applies when you do kissing balloon. The size of the kissing balloon in the overlap portion is not the summation of the balloon size. It's actually 2/3 of the summation of the distal balloon. Very important to know that rule, 2/3 of the distal summation, to size your POT and to know actually what balloons, what's the size of the balloon, the kissing balloon in their overlap portion. Okay, so you POT here with a 3.75 millimeter balloon. Okay. So now I will go to the next step. So we did the POT, and now after doing that, we assess what's the result in the side branch. You have to decide after doing that, should I now touch the side branch? And the answer to that is yes. Like I said, if after doing POT, is there a residual stenosis over 75 to 90%? Again, different studies do use different number. Most of them use 75%, and it depends on the size of your side branch. If it is yes, then you have to rewire that side branch while keeping the jailed wire as a marker. You rewire that side branch. And as I explained to fellow, this is the single most difficult step in bifurcation stenting, rewiring side branch across a stent. Your wire will have a propensity to go behind the stent struts. That's why POT is important, but even that is not always enough. If you want to become good at bifurcation stenting, you have to be good at finding technique of wiring through a stent, the side branch through a stent. It's one of the most difficult techniques in interventional cardiology, I think. Okay, so you need to rewire, and I'll give you some technique of how to rewire. But you try to rewire, often use a non-polymer wire. A polymer wire like Whisper is slippery and with no tactile feedback. It will go behind the struts and you're not going to be aware of it. Try to use something like BMW Pro Water, a non-polymer wire, less likely to slip behind. And if it does slip behind the struts, you will feel a scratch as you're advancing it or pulling it, and you know you're probably behind the struts. So you rewire that, and preferably through a distal struts, not a proximal strut, and I'll explain why. So after you rewire it, then you advance a balloon. And if you're able to advance a balloon that tells you you're not behind the struts, then you advance the balloon, you take the jail wire out, and you post-dilate that side branch with a balloon size 1:1. I prefer to advance a non-compliant, a compliant balloon, simply because it's hard to advance a higher profile compliant balloon through stent struts. So I advance a compliant, short compliant balloon, and I post-dilate here. Potentially, if needed, you can post-dilate at high pressure, but most importantly, sized 1:1. After that, what you need to do is, after that, you absolutely need to finish with a kissing balloon inflation, where you advance another balloon in the main branch size to the distal vessel, again, according to fractal law, size to the distal vessel, so that the summation of both balloons gives you an appropriate size in the main branch. So size to the distal stent, plus that balloon, you do kissing balloon. You try to align the dots so that you get a proper and symmetric expansion in the overlap area, and actually try not to overlap them too much in the main branch vessel, because they can create a oval distension, oval deformation of the main branch stent. Okay, so you do that kissing balloon. I do my kissing balloon by up to 12 atmosphere, 10 to 12 atmosphere. Not higher than that, but up to 12 atmosphere has been used in studies. That's basically the steps. Now, the EBC recommend after your final kissing balloon inflation, they do recommend, even if you get a good result, to redo POT, just to protect that main branch stent from the oval deformation that occurs when you put two balloons side by side. It's not going to be perfect circumference when you're doing two balloons side by side. So they prefer that you re-POT that area, which should not affect your side branch. If anything, should improve your side branch. Okay, so those are the ideas. I will mention in a little bit that what you can do here, instead of post-dilating that side, rewiring and post-dilating that side branch when it's pinched over 75 to 90, you can choose to FFR, rewire it with an FFR wire, and decide whether you need really to balloon it and do kissing balloon. Okay, so there are two ideas that are always mandatory: POT and final kissing balloon inflation for any two-stent technique, or after you touch, anytime you touch that side branch, including with just balloon dilatation, you always need to finish with a kiss. POT before, kiss, probably POT after, preferably POT after. I'll give you some example here. This is from a case I did yesterday. This is a left circumflex, let's say bifurcation into OM2 and let's say main left circumflex. It's 1-1-1, but it's a true but non-complex bifurcation because it's only the very ostium that's involved. So here, what we did, we double wired, pre-dilated that OM2 with a 3 millimeter 1-to-1 balloon, good predilatation. Then I stented across the OM2. This is the result. It's a very good result. It's less than 75%. There is a plaque carinal shift and probably plaque shift in that OM, but it's an acceptable result, as I mentioned here. It's less than 90%, probably around 75 or less percent. TIMI3 flow, it's perfectly appropriate to leave this alone. You have to take into account, if you choose to be aggressive here, it will be very hard to rewire a stent in this case. Like I said, it's hard to rewire a stent. It's particularly hard in a distal vessel, particularly hard if you have to cross multiple tortuosity. This left circumflex is very tortuous and calcified. So you want to rewire across that, you have less wire control. And as you're trying to rewire, you're not going to have issues just crossing this and not going behind the struts. You're going to have issue of wire wrap. You're going to wrap your wire with the wire that's already in the main branch. So you're going to have problems here with rewiring. So, take into account how difficult this is when you're choosing two-stent strategy, but also when you're choosing what cutoff I use for my provisional, okay? This is another case done by another operator. Here, this is LAD diagonal bifurcation, true bifurcation. They pre-dilated that side branch, then they stented across and did POT, as we did here. We did POT, and they got a decent result, probably 80–90% diagonal stenosis. They left it alone, which I think is appropriate based on that algorithm. Okay, you could have done also FFR. It would have been okay to balloon it, but I think the simplest strategy is appropriate and probably most appropriate here. This is another case I want to show you here quickly. This is a distal left main complex bifurcation into the LAD, heavily calcified and severe into left circumflex. The left circumflex is probably in the 80% range, heavily calcified and long. This is a case where we did planned DK crush strategy. It's very appropriate, very large, heavily diseased left circumflex that gives collateral to the RCA. This is another case. People don't talk about that. And I want to show that for a reason. Oftentimes when we say main branch, side branch, we're talking, people think of left main and LAD. And you know that the main branch is the LAD, the side branch is the diagonal. But how about when you have left circumflex and a big OM or two OMs? Well, which one is the main branch? And both are diseased. Well, which one do you choose as main branch? Which one do you choose as side branch? In the past, I used to think, well, both branches are equally important. This is not LAD diagonal. Therefore, maybe we should double stent those. No, it's true that both branches are equally important, but you should, the provisional strategy still applies. You just choose one of them as your main branch, and you choose the other one to be treated provisionally. Still, in those cases, provisional is as good as a two-stent strategy. And which one do you choose as your main branch? It depends on which one is tighter, maybe which one has a larger territory, and which one is easier to wire potentially, and which one is easier to rewire. Okay. In this case, I decided to, in this case, for example, what I would do, I would place a stent, I would wire both, I would stent across into the lower branch and jail that upper branch. I think the lower lesion is tighter and maybe has a larger territory. Okay. So again, provisional still applies. For example, in PDA, PLB through bifurcation, this RCA, still you choose one as your main branch and the other as your side branch to be treated provisionally. It's just that putting two stents in those cases is not going to improve long-term outcomes. You think, you don't want to just balloon one of them, but guess what? Putting 2 stents is associated with a higher risk of restenosis than if you're putting 1 stent across that. So that's why the provisional approach still applies. It's a different animal putting 2 stents in terms of restenosis and MACE. This is another case. This is also not much talked about. This is what we call the 001. It's isolated side branch stenosis, where the side branch, this is again OM circumflex, is as important as the circumflex. The way I would approach this, I would double wire, I would stent from the main branch into the side branch, then do POT of the main branch, and decide whether I need to rewire that main circ and balloon it. I will rewire it and balloon it if it is over 75 to 90% stenotic after POT of that main branch. So I will stent across in this case and provisionally maneuver this one if needed. So role of FFR quickly here. As I explained, instead of ballooning, choosing to balloon a side branch, if it is over 75% in a provisional strategy, you can choose to FFR it first. And this is based on this concept that I explained earlier, that a lot of the narrowing that occurs after stenting is geometric distortion and carina shift. You're pushing the lower main branch and distorting the geometry. It's not plaque shift, as I explained earlier, and therefore less functionally significant. But it's also based on that landmark study published in 2005. They took patients with side branch lesion after main branch stenting that were over 75% side branch lesion, and they found that only 25% were functionally significant by FFR. This is an interesting spread. So they took side branch that were over 75% stenotic after main branch stenting. And really, between 75 and 90%, this is your FFR. Overwhelmingly, your FFR is non-significant. Only a small subgroup had a significant FFR between 75 and 90%. When your side branch is over 90%, even then it was half-half. Your FFR was significant half the time and non-significant half the time. And this can explain to you why in my algorithm, I use that 75 to 90%. Most randomized trials of provisional versus 2 stent use 75. I kind of like 90% based on that FFR study. Okay, definitely 90% in the case of deciding to stent. Okay, not just that, they showed that the MACE at 9 months, there was no TVR in patients with FFR over 0.75, even though their stenosis was narrow, was severe. And there was no MACE in the FFR less than 0.75 that were just ballooned and in whom you obtained, after ballooning, you improved the FFR, but you are still left with a bad stenosis. They still had no MACE with those patients. So that tells you why side branch narrowing, you should not get obsessed with it. Most often is not functionally significant and does not affect long-term MACE. This is particularly true in the case of non-true simple bifurcation, but it does also apply, those ideas do apply to true bifurcation. Actually, in this study, most lesions were true bifurcation in that FFR study. Still, leaving the side branch alone was appropriate. I will try to, in the time remaining, I will try to explain some technical tips. One idea is what guide to use. That's a matter of debate. I prefer to use, not just I prefer, 6 French is a very appropriate guide when you're doing simultaneous balloon, but it's also appropriate when you're doing simultaneous stent balloon, as long as the stent and the balloon are less than 3.5 millimeter. It will be tight, but a 6 French does fit stent and balloon that are less than 3.5 millimeter. Therefore, with a 6 French guide, you can do actually sequential crush, you can do DK crush technique, you can do culotte, and you can do tap, T with protrusion, which I will explain in a little bit, where you do simultaneous stent balloon. You only need 7 French if you're bigger than that. If you're doing stent balloon bigger, simultaneous stent and balloon bigger than that, such as in left main, it's probably better to go with 7 French in left main. Also, if you want to make your life easier, it's okay to go with 7 French because it will be less tight to advance and deploy a simultaneous stent balloon. But again, 6 French is appropriate for simultaneous stent balloon less than 3.5 millimeters. Now, how to use side branch, how to perform side branch rewiring. I will give you some tips. One, how to shape the wire. One, you need to wire the shape the wire in this way. I do 2 tips, a distal tip and a proximal tip. The proximal tip, the length of it depends on the length of the vessel. You have a large here, let's say. You have a large caliber vessel. Here I will put a 5-6 millimeter tip on it proximally. You have a smaller vessel. I will put a smaller proximal band, a smaller length. So this, the length of this, where you put it, depend on the caliber of the main branch. The sharpness of it, whether you do it 45 degree or you do it close to 90 degree, depends on the sharpness of the main, of the side branch takeoff. So length and sharpness, those are the 2 things we do. Second idea, the distal, I put a distal tip always 1 to 2 millimeter. This helps me stay centered in that side branch and not prevent the wire from touching the wall of it and dissecting it. Okay. So the wire tip is extremely important in your success, as I always insist to fellows. It's an art that you need to acquire. So wire tip shaping. 2, like I explained, try use non-polymer wire if you can. If you absolutely have to, in tortuous and difficult cases, you need non-polymer wire, but try not to, at least first line. Do POT, as we explained. It's key to do a good POT before you rewire. Another technique is you wire you shape the wire properly, then you advance it distally, and you try to hook the ostium of the side branch on your way back. That is good because it helps you also wire the distal struts. You may knuckle it distally, and knuckling it ensures that you're not behind the struts, and pull back and engage that side branch on the way back. Okay. Another technique in extremely sharp angulation, where you have a reverse angle. Your angle is not down like this, your angle is up. In those cases, you can do a reverse tip on the wire. So you do really reverse sharp angle in reverse. You don't do your wire tip like this. You do it in reverse with another angle. So this is the shape we do. It's like a V square angle. You try to hook the side branch and get it on the way back. You can also do, in those difficult cases, you can do the balloon stop technique, where over the main branch wire, you inflate the balloon distally, so that will force your wire to be deflected in the side branch. I want to try to stay for 10 more minutes. I want to explain more techniques. So I know some of you have to leave, but those of you who can stay, please stay, and I will explain more ideas. Okay. So another important technique of how to wire the side branch. So one very important one is how to shape your wire and how to maneuver it. Okay, whether go distally and pull back, and potentially knuckle it distally, U-shape it and pull back. Another very important technique is to use twin pass or double lumen catheter. The twin pass just quickly it's a 2-lumen catheter, 2 separate lumens. One of them is in monorail rapid exchange lumen. Another one is an over-the-wire lumen. The monorail lumen goes over the main branch. This is how you advance it. You advance it over the main branch wire, in a monorail fashion. The over-the-wire portion is the portion that opens on the side into the side branch. So you advance the monorail over the main branch wire, then you advance a wire through the over-the-wire portion of it. You advance it into the side branch. You shape the wire properly. You position that portion across the side branch, and you try to advance into it. It has two advantages, that the balloon catheter. One, it keeps you away from the struts, because any catheter, including balloon catheter, is not going to go behind the struts, is unlikely to go behind the struts. So it keeps you away from the struts. So it keeps your wire away from going behind the struts, keeps you centered. One, that's one. Two, it prevents that wire from prolapsing back. One issue is that sometimes you hook the side branch, but as you're advancing the wire further, it falls out. But having that distal support, that distal bulk, prevents the wire from slipping back. This is another example. This is one, not a twin pass, but this is a nice technique I like that applies to how you wire side branches. It's called the hook it and flip it technique. So it's a very sharp side branch here and very tight. So the way it was wired, you hook it, but it was hard to advance it. So after you hook it, you turn it around like a wheel and you wait for it to fall. You don't push it. So you hook it and you flip it around. You counterclock and clock, flip it around. Be patient. Don't push it much. You flip it around with a forward tension, not a push, and it will fall. Turning wheel or hook it and flip it technique. Okay, and you see how it falls. And that will help prevent wire prolapse. Just a few other tips here. I use compliant balloon myself, I explained, for initial side branch dilatation, because in my opinion, it's often difficult to cross with a non-compliant balloon, but you can use a non-compliant as a second line after you've dilated the side branch with a compliant balloon. Also, when you're dilating the side branch through a stent, make sure that balloon doesn't slip all the way beyond the stent struts, because then you may have a hard time taking it out, because in that case, you would not have dilated the stent struts. So be careful with that. I will explain another important technical idea. Why do you try to wire distal strut as opposed to proximal strut? When you're rewiring, why you rewire here? This step, the rewiring step. Why do you rewire distally, not proximally? The first idea I want to tell you, do not obsess with that. I know every meeting you go to, they obsessed, every algorithm, every textbook, they are obsessed with this. In my experience, the most difficult thing is to wire that side branch in any way you can, not behind the struts. If you get this, that's great. Take what you get. That's my most important advice here. If you're a perfectionist and if you're really good, try to wire distally. Why? If you wire distally, when you balloon after you wire distally, you will push that main branch stent upward into the upper arm of the side branch, which is the arm that's difficult to cover. And you'll create a scaffolding of that upper arm of the side branch, okay? So you'll create some scaffolding of the side branch ostium, of the difficult part of the side branch. Okay? The easy part to cover of side branch is the lower. The harder part is the upper one. So you create scaffolding of that side branch. Conversely, if you go proximally and you balloon the post-dilatation of the side branch, when you balloon, you're going to push those struts actually across the center of the side branch, and you'll actually potentially occlude that side branch and distort the main branch stent. So try to cross distally. You create a great scaffolding, and it makes it easier to stent if you need to stent it. Okay. Now, I want to explain the tap technique. Let's say, and here I go back to the algorithm. So I told you, if you don't like your balloon result, you have, despite ballooning, TIMI less than 3 or persistent side branch over 90%, then you do provisional stenting. And here I'll explain the provisional stent technique. The most important one is tap, T and protrusion. So the way we do tap is, after we've done POT, after we've done ballooning of that side branch, we advance a stent into the side branch and we advance a balloon into the main branch. Okay, the balloon is again sized as always. The main branch balloon, when you're doing double maneuvering, you size it to the distal main branch. So you advance those and you initially deploy the side branch stent while the balloon is deflated. Then you deploy it at normal nominal pressure. Then you pull back that balloon of the T-stent and inflate it at high pressure. Then you do a kissing balloon inflation of the main branch balloon and the side branch balloon, okay? The idea here is that you never let that stent touch the other wall. You position it to cover the ostium, including, like I said, the upper arm of the ostium, which is one more difficult to cover. You position it in a way to just cover that, but not to touch the opposite wall, okay? You initially deploy it, pull back, dilate at high pressure, and the balloon is preventing it from touching the balloon in the main branch. Then you deploy both in a kissing fashion, preventing it from touching. Now, there are several caveats to T-stent. One, this idea, this is how T-stent looks like. So you will have a piece of metal. The idea of the T-stent is that you will have a piece of metal called neo-carina hanging in the main branch and the main branch stent. And that's why a lot of operators don't like it. This is unlike the crush technique where that stent is crushed against the wall. You don't have a carina hanging in the main vessel, or the culotte technique where that stent is deployed all the way and touches the opposite wall of the main branch, and you have double circumference stents into the main branch, but you don't have anything hanging in the middle of the lumen. So this is the difference between T-stent, crush, and culotte. This is how it looks, the T-stent, ideally, after you've done the kissing balloon dilatation. I want to show you there are conditions that are necessary for you to be able to do the tap. So the ideal situation is the sharper that angle, the closer it is to 90 degrees, the better your tap will work, or the T-stent will work, the less overhang you'll have in the main vessel. But that's not the only feature. So that's why we like to use tap in vessels that are steep, over 60 degrees, closer to 90 degrees. That's not the only feature. You have to account for how large the main branch is and how small the side branch is. If you have something like this, so you can do your tap. So big main branch, small side branch, you can do your tap even in a narrower angle. Even if the angle is maybe 45 degrees, you can do your tap. You're not going to get a lot of overhang. Conversely, if you have a small main branch that's the same size of the side branch, well, even a 60 degree will cause too much neocarina, too much overhang, and you probably should avoid tap. So you take into account those: angle more than 60 degree, small side branch, large main branch, okay? You want that overhang in general to be less than 1 millimeter, okay? Certainly something like that is not attractive. If you have too much, if you think you're going to have too much overhang, as in those case scenario, then the technique you use should be what we call the reverse crush technique, where, okay, you deploy the stent as I'm showing with a balloon here in place. Then rather than do simultaneous balloon inflation, so you deploy the stent, and instead of simultaneous stent balloon inflation, you just, after stenting, you inflate that main branch balloon and you crush, you smash that stent against the wall. And that's the crush. Then you have to rewire and do a kissing balloon dilatation again. So crush, you smash that stent. You don't deploy simultaneously. You smash it and you have to rewire it and do a kissing balloon inflation. You rewire, and it's actually this one. You rewire and do a kissing balloon inflation. The main advantage of tap is that you don't have to rewire. You just rewire once, the same rewiring you did for your side branch post dilatation. You don't have to rewire again. With all those other ones, the crush and culotte, you have to, including the reverse crush, you have to rewire again and rewire again here. So that's a main advantage, considering that rewiring is a single most difficult step. That's why tap is very handy. I want to show you, this is from the EBC white paper, which really seems to like the tap technique. They have several examples where they use tap here as a provisional technique with an angle of look at this angle. It's less than 45 degrees even, they use tap. So this is to tell you that really, I know some operator prefer tap for really something close to 90%, but I don't think that's absolutely true. You know, if you have the perfect conditions, the better condition, the proper sizing of the main branch and side branch, you can apply it to narrower angle. Not just that, if you have the perfect imaging and you know how to position, you can also apply it to narrower angle, as they did here in those two cases in the EBC paper. They applied tap to an angle of 30 degrees. Now, how to position the tap? I said you should position till you cover that upper arm of the side, till you barely cover that upper arm of the side branch. Here, let me show you the picture. Till you barely cover that upper arm of the side branch. Not anymore, just barely. And you will be barely into the main branch, as much as needed, but no more than you need. And how can you tell practically that's the case? Really, the best tap is when you can use the stent boost technique, which all new labs have. Stent boost. So you can see actually the main branch stent struts, and you position your stent dot just inside the main branch, just inside it, not a quarter of a millimeter more. That's a perfect tap. And in this case, you can apply tap to narrower angle. Also, if you've crossed across the distal main branch stent, you can do tap with a narrower angle. So you position it with a stent boost technique. This is a perfect tap, and you get the minimal overhang. Okay, then you do the next step we talked about, the kissing balloon inflation. And it's preferable to do, as in any provisional, it's preferable to do a repot at the end of the proximal portion of the main branch, proximal to that overhang of the T-stent. And here's another illustration of why they can apply it to narrower angle. One is, like I said, the sizing of the main branch and side branch. Two is very good positioning under stent boost of barely inside the vessel, the main branch vessel. Three, if you're crossing through the distal struts. Well, when you're crossing through the distal struts, you're scaffolding that upper arm of the side branch, and therefore you need to put a shorter stent and shorter overhang to cover that upper arm of the side branch. And that's why wiring the distal strut is helpful in tap. It allows you to have less overhang. Again, you really need to do stent boost to see all those things. What I do in the absence in old labs with no stent boost, I do the cheap technique, which is not great. I position my tap stent. I position the dot till it barely touches the balloon that is stationed in the main vessel. Not overlap with it. I make it barely touch it. That's not the best way. You should use a boost technique and make that dot barely inside this boosted stent, main branch stent. Okay. So I should finish here. I do want to mention one more idea, and I will be done here. It's an interesting technique that I have not used, but it's gaining mainstream application, and I really find it interesting. So we talked about jailing a side branch to protect it, jailing it with a wire. But there is this idea of jailing the side branch, not just with a wire, with the whole body of a balloon. So you actually stent that main branch across, not just a wire, across a balloon. Okay, you jail a balloon. So here, how it's done. The reason you do this is it's particularly applicable when you think you have a complex true bifurcation with a high risk of side branch occlusion, yet I don't want to do two-stent strategy. It will be very hard to rewire that side branch. So I don't want to do two-stent strategy, yet provisional strategy is not good either, because I'm going to occlude that side branch and I will have a hard time rewiring it even once. Well, the best strategy is try to reduce the chance of a side branch occlusion. So a Turkish group and then a Chinese group started to use this technique where, okay, you position your main branch stent and you don't just wire the side branch, you position a balloon in that side branch. You can predilate it, like I said, okay, you predilate that side branch. Then when you're stenting the main branch, you're keeping the balloon in, or better, in this particular paper, they are inflating the balloon at low pressure, 3 atmosphere. So they are doing main branch stenting with either a stationed balloon, gel balloon, or a gelled, mildly inflated balloon at 3 atmosphere. Then after that, they take the balloon out, they do POT, and they assess the result. You have half time or less, more than half reduction in the risk of side branch occlusion when you're using a gel balloon technique. The idea of a gel balloon is that the balloon that you place during stent deployment, normally when you stent, you're worrying about plaque shift, okay, into the side branch. Well, that balloon will prevent plaque shift into the side branch. It will basically push the plaque into axially, and it will also push the plaque outwardly into the outer vessel. So rather than that plaque being shifted into side branch, the plaque will be shifted into the outer main branch, main vessel, okay, or axially outside the stent. So that will reduce the narrowing. And the POT will reduce the carinal shift. So you get the best of both worlds, less plaque shift and less carina shift. All right, I will stop here. Any questions? I know I talked about a lot of ideas and a lot of techniques. Anybody has questions?
Thank you, Dr. Hanna. This was really great.
Okay, thank you.